Welcome back to this next video in which we are discussing cardiac arrhythmias. Okay, so we're in the process of discussing supraventricular arrhythmias, specifically those which arise from the atria. We've now discussed atrial ectopic beats, and what I want to move on to discussing is atrial flutter and then atrial fibrillation. Okay, so we'll start off with atrial flutter and then we'll go on to atrial fibrillation. Okay, so atrial flutter is produced by yet another new mechanism. So we're going to have a look at another new mechanism by which arrhythmias can arise, namely the concept of a reentrant loop. So this is the first thing I need to explain to you. What is meant by a reentrant loop? Because this is what's going to drive atrial flutter, and indeed also it's going to be a major driver of atrial fibrillation as well. So we need to understand what is meant by a reentrant loop. So normally, electrical signals propagating through the myocardium cannot follow loop pathways, okay? In a reentrant loop, what's going to happen is the electrical signal is going to go round and round in a loop, and it's just going to continue regenerating itself continuously. So normally, to get a reentrant loop, what has to have happened is there has to be some injury to the myocardium. Usually what happens is you have a myocardial infarction, survive the myocardial infarction, and then the infarcted portion of tissue, that's replaced by a scar. You see, although the heart is one of the most important organs in the body, its capability to regenerate itself is incredibly poor. So when loads of cardiomyocytes have died because of myocardial infarction, they unfortunately are not replaced as they would be in other organs such as the liver, which has incredibly good capacity to regenerate. Instead, what happens is the body brings in fibroblasts, which then chuck out collagen, and they produce a lovely, strong piece of tissue, connective tissue, but of course this is useless as far as actually conducting action potentials is concerned, and certainly as far as contraction is concerned. Okay, so once you've had an MI and loads of cardiomyocytes have died, they do not get replaced. Instead, what happens is you replace them with connective tissue, which is non-conductive and non-contractile. Okay, so let's imagine that in the wall of our atrium then we have got a nice big scar due to a past myocardial infarction. So let me just draw this here. Okay, what can now happen potentially is you can get a reentrant loop formed around this scar. So let's imagine that the piece of paper here is the wall of the atrium and we've got this scar here. So this is all not cardiomyocyte tissue, this is fibroblasts with connective tissue. Okay, so it does the job of filling the gap, but it doesn't conduct action potentials. What can potentially happen around this is you can get a reentrant loop, and let me explain this by drawing a few cardiomyocytes around the edge. So let me just draw a few cardiomyocytes. So let's say these are the cardiomyocytes surrounding this scar tissue here. Okay, let's say that we have one cardiomyocyte here, and it's going to pass an electrical signal. Let's say it's got an electrical signal, and it's going to pass it in this direction. Okay, so let's say this cardiomyocyte passes the electrical signal onto this one. So the orange one has passed it onto the next one along, the next one along will pass it over here, this one will pass it to this one, etc. It will go round this loop, and then it will get to this last one in the loop, and I'm sorry about that slanting there. It will get to this last one in the loop, which I'll colour in green here. Now, the question is this: what happens if the orange cardiomyocyte has gone back to the resting state? What happens if it's recovered from its action potential and it's now ready to receive another action potential? Well then, the green cardiomyocyte can just pass the electrical signal right onto the orange cardiomyocyte again, and this signal can go round and round and round in a loop like this. Okay, and this is what is meant by a reentrant loop. It sets up what is often referred to as a circus rhythm. Okay, this concept that the electrical signal can go round and round and round, and that's compared to the circus, so it's called a circus rhythm. Okay, so reentrant loops can give rise to circus rhythms where the electrical signal goes round and round and round this loop and regenerates itself continuously. Now note, such a reentrant loop never occurs in the nice healthy heart. So if we bring back up our nice healthy heart here, the sinoatrial node generates the electrical signal, it propagates down the atria, but then it hits this point where it cannot pass any further, and bang, the electrical signal is then killed, it passes no further. Okay, it doesn't start looping round anywhere. Then it can pass through the AV node at this, it can pass through the atrioventricular septum at this one point, which is the atrioventricular node. It follows the conduction system for the ventricles down here, and then it's released onto the ventricular cardiomyocytes, and again it reaches ends wherever it goes. So in the context of the interventricular septum, it will reach termination, it propagates up, bang, it reaches the end of where it can go. Okay, in the context of the major portion of the ventricular walls, it will reach the outer portion of myocardium, and then it can't go any further, bang, it's gone. Okay, and then also in the context of the posterior ventricular walls here, again it reaches an end and it can't go any further. So you don't have any loops established in this way. Now, let's go back to our atrial wall here, where we have got this reentrant loop established. Potentially what can then happen is you can get this happening. The electrical signal can just go round and round and round and round. And when this is happening, what will also be happening is the cardiomyocytes here will be throwing the electrical signal off to their neighbouring cardiomyocytes, so to all the cardiomyocytes around them as well. Okay, and it will be propagating throughout the atrial walls therefore, and then it will reach the AV node, go down the AV node and propagate to the ventricles as well. So in fact, one of these reentrant loops can end up driving the entire heartbeat basically. It can take over for the sinoatrial node and drive electrical signals that will just go, which will propagate through the entire heart. So these reentrant loops then, they can establish electrical signals that are generated at an extremely rapid rate, and this is the mechanism that's going to underlie atrial flutter. So in atrial flutter, you're going to get one of these reentrant loops established in the walls of either your right atrium or your left atrium, and it's going to be driving a very high generation of electrical signals that will propagate through the atrial walls. Okay, right, so atrial flutter then, it's driven by this, and you can actually get the atria contracting at a rate of up to 300 beats per minute. So that's the really mad extreme, that it can actually generate electrical signals at rates of up to 300 beats per minute. Okay, now, that does not mean that your heart rate goes up to 300 beats per minute, because the atrioventricular node is not going to conduct 300 electrical signals through it every minute. Okay, so even though the atria are receiving 300 electrical signals every minute, the AV node will not conduct all 300 of them down to the ventricles, so a huge number of them will be blocked. However, still, a lot more electrical signals than should be getting down to the ventricles will get down to the ventricles. So the AV node won't conduct all 300, that's a mad number, but it will end up conducting a lot more electrical signals down to the ventricles than it should in the ideal setting, which is about 75. Okay, so it will end up conducting a lot of them, but not all of them. Okay, it won't conduct all 300, so it will block some of them. Okay, so let's now think about what the ECG of someone who is suffering from atrial flutter will therefore look like. Well, we're going to have a lot of P waves which will be generated by each of these electrical signals propagating through the atria, and then not all of the P waves are actually going to lead to QRS complexes and then T waves. Only a few of them are actually going to be conductive by the AV node down to the ventricles and will therefore result in ventricular depolarization. Okay, so what the ECG is going to look like is we're going to have P wave after P wave after P wave, and then occasionally a QRS complex. Okay, and we probably won't see the T wave because as soon as the QRS complex is over, you'll then have P wave, P wave, P wave, so the T wave will often be hidden amongst the P waves. Now, will the P waves be their normal way up, i.e. an upward deflection from the isoelectric line, or will they be inverted? Well, that question depends on where the reentrant loop is actually positioned. Again, this is very much so like the ectopic foci discussion. If the reentrant loop is right at the top of the atria, then when the electrical signals propagate down from it, they will be propagating through the atrial walls in an anterograde fashion. Okay, so bringing back up this picture here, if the reentrant loop is up at the top, then when the electrical signal propagates through the walls of the atria, it will be propagating in an anterograde fashion, and therefore the cardiac vector for that propagation will be pointing from the right atrium down to the left leg, and therefore we'll get an upward deflection on our lead 2 ECG. If, however, the reentrant loop is near the bottom of the atria, then when the electrical signal propagates through the atrial walls, it will be propagating in a retrograde fashion, and you'll have an inverted P wave. However, they don't look vastly different because of the rate at which these P waves are being generated. Okay, and let me explain what I mean by that. So if I actually draw the ECG here, let's say that the reentrant loop is near the top, so the P waves are going to be an upward deflection. Let me draw it here. So here's a P wave, and then you'll go straight into another P wave, so actually it becomes almost sinusoidal, like so, and then let's have another P wave, and let's say that one might actually result in a QRS complex. Let's say the AV node is going to conduct that one down. Okay, so here's the QRS complex, and then you'll have another P wave after that. And this is what I mean by the T wave not really being that apparent, because it's covered up by the hugely rapid P waves here. Okay, so this is what the ECG then of someone who is suffering from atrial flutter will look like. You've got like a sinusoidal wave which is made up of the continuous P waves, and then just dotted about the place you'll have QRS complexes which are formed by the rare occasion when one of these P waves actually does result in ventricular depolarization because the AV node has let it pass through. Okay, and these waves here that are due to atrial depolarization, these are called flutter waves. Okay, so they're described as flutter waves here. Right, so this is what occurs in atrial flutter, and this is what the ECG of someone who is suffering from atrial flutter is going to look like. How do we actually treat it? Well, again, treatment is going to focus on trying to prevent as few trying to prevent the electrical signal actually getting down to the ventricles. So the idea is the atria contracting at a ridiculous rate is not actually too problematic. What we want to prevent is the ventricles contracting at too high a rate. Because remember, if the ventricles contract at too high a rate, what we're going to end up with is we're going to end up with a very low stroke volume, because the ventricles will contract and then they won't relax, because they'll only get to relax a tiny bit and then they'll be contracting again. Okay, so you won't get proper ventricular refilling, and that can hugely compromise stroke volume. Okay, so for that reason, we want to try and reduce how many of the electrical signals from the atria are actually getting down to the ventricles, so that even though the atria might be contracting at a ridiculous rate, we can hopefully prevent ventricular tachycardia and therefore maintain a healthy stroke volume. Okay, so how are we going to do this then? Well, we've seen many of the drugs that we can use to do this. We're going to, once again, try and reduce the conduction velocity of the action potential along the cell membrane of atrioventricular node cardiomyocytes. And if we do that, that will result in fewer of the electrical signals from the atria actually making it through to the ventricles. Okay, so we've already seen two classes of drugs that we can use. So we can use beta blockers, and remember the way that the beta blockers will work is they will bind to the beta-1 adrenoreceptors on the surface of the atrioventricular node cardiomyocytes, and they will prevent the noradrenaline or norepinephrine from the sympathetic nerves actually activating those beta-1 adrenoreceptors, and that will then reduce the sympathetic stimulation onto those atrioventricular node cardiomyocytes, resulting in a reduction in the speed at which they conduct action potentials. So remember, sympathetic stimulation on the AV node cardiomyocytes causes them to conduct action potentials more rapidly. You have that tonic level of sympathetic stimulation onto the AV node cardiomyocytes, and beta blockers will remove that and hence reduce the speed at which action potentials are conducted along the cell membranes of AV node cardiomyocytes. Okay, so beta blockers are an option. We've also got those L-type voltage-gated calcium channel blockers, so CCBs here. Remember, we use the phenylalkylamines such as verapamil and benzothiazepines such as diltiazem because those are quite good at blocking the L-type voltage-gated calcium channels in cardiomyocytes. We don't generally use the dihydropyridine drugs, even though they're very famous, because those are more better at blocking the L-type voltage-gated calcium channels in vascular smooth muscle cells. And remember, by blocking a few of the L-type voltage-gated calcium channels in the atrioventricular node cardiomyocytes, we can slow the propagation of the action potential along the cell membrane of the atrioventricular node cardiomyocytes. Okay, so those are calcium channel blockers. Now there are some more drugs that I want to introduce you to, well actually just one here that I want to introduce you to that can also reduce the rate at which action potentials are propagated along atrioventricular node cardiomyocyte cell membranes and which therefore can reduce how many action potentials are actually going to be conducted from the atria to the ventricles. Now this drug is a more dangerous drug, which is why it's reserved for more serious conditions such as atrial flutter rather than just atrial ectopic beats. Okay, so the drug is digoxin. And it is a molecule that is isolated from the foxglove plant, also known as the digitalis plant, and it is actually extremely poisonous. It's the reason foxglove is extremely poisonous. Okay, so how is digoxin then going to actually achieve a reduction in the rate at which the action potential is conducted along atrioventricular node cardiomyocytes? Well, the mechanism isn't particularly well understood, but it's thought to act on the parasympathetic nerves which innervate the heart. Okay, so digoxin is believed to act on the parasympathetic nervous system neurons which innervate the heart, and it's believed to actually cause an increase in the amount of acetylcholine that they are releasing. So somehow, by mechanisms that are not particularly well understood, digoxin goes into the parasympathetic nervous system neurons, axon terminals that are innervating the heart, and results in them releasing more acetylcholine onto the heart muscle cells. Now, when acetylcholine is released onto the atrioventricular node cardiomyocytes, we know what it causes. It binds to M2 receptors on the surface of those cells, and it causes a negative dromotropic effect. It reduces the rate at which action potentials are conducted along the cardiomyocyte cell membrane. So here we are potentiating the parasympathetic nervous stimulation, the parasympathetic tone to the atrioventricular node cardiomyocytes in order to actually reduce the conduction speed of action potentials through the AV node and therefore reduce the number that will actually make it through from the atria to the ventricles. Okay, so digoxin is therefore described as a parasympathomimetic drug. Okay, it's working here to increase the parasympathetic tone onto the cardiomyocytes and hence to reduce the conduction velocity of action potentials along the cell membrane of those atrioventricular node cardiomyocytes. Okay, right, so that's digoxin. Now let's talk about one final drug which can actually help to prevent the circus rhythm here, can actually help to prevent the reentrant loop from having this cycle of the signal going round and round and round. So the final drug that I want to mention, which can be used to treat atrial flutter, is a drug known as amiodarone. Okay, now amiodarone lengthens the cardiac action potential. Okay, so let me draw a picture. So it lengthens the cardiac action potential in all of the cardiomyocyte cells, but in particular we're going to be interested in its effects on these atrial cardiomyocytes here. So let me just draw a picture of what the the action potential is going to look like in these atrial cardiomyocytes. So remember, the electrical potential difference across the cell membrane will start off at negative 80 millivolts. Then you'll get depolarization up to negative 40 millivolts, and then the voltage-gated sodium channels will open to cause a rapid depolarization and the upstroke of the action potential up to about plus 20 millivolts. Then the voltage-gated sodium channels will inactivate, so this is all just revision rather than an in-detail discussion here. Voltage-gated sodium channels will inactivate, and voltage-gated potassium channels, a few of them will start to open, the early ones. Remember, voltage-gated potassium channels are opened usually at the threshold potential of negative 40 millivolts, but the time it takes them to actually get around to opening is generally very slow, but it does vary. There's a huge number of different voltage-gated potassium channels, and different types of voltage-gated potassium channels will open at different rates. Okay, so initially what happens is some quite fast voltage-gated potassium channels start to open, and those cause the downward deflection of the electrical potential difference across the cell membrane. Then we get the plateau phase of the action potential, which is due to the L-type voltage-gated calcium channels opening, balancing the voltage-gated potassium channels that are opening. Then the L-type voltage-gated calcium channels begin to close, and more of the voltage-gated potassium channels begin to open, and that causes the repolarization of the electrical potential difference back down to negative 80 millivolts, the repolarization phase of the cardiac action potential. Amiodarone is going to lengthen the cardiac action potential by blocking voltage-gated potassium channels. Okay, so it will mean that this phase of the action potential takes much longer to complete, so the plateau phase will generally go on for longer, and the repolarization phase will be much less steep, like so. Okay, so this is what the action potential inside cardiomyocytes might look like after amiodarone therapy. It lengthens the action potential in the cardiomyocytes. Now, why is that something that we'd actually want to do? Well, note, this means that it's going to take longer for cardiomyocytes to recover from an action potential. Remember, to recover from an action potential, you have to repolarize the electrical potential difference down to below negative 40 millivolts, so that all of your voltage-gated channels can go back into the resting state. Okay, otherwise those of them will still be inactivated. So only once you've done that will the cell be ready to actually fire another action potential. Okay, so amiodarone is effectively going to mean that cells are going to be refractory to re-stimulation for a longer period of time. It's going to take them longer to recover from an action potential. Now, if we've got this circus rhythm here, the cells have to be ready to conduct an action potential again very, very quickly. So if we give a drug that means that they're not ready to conduct another action potential again because they take much longer to be ready to conduct another action potential, then potentially what will happen is the electrical signal will get back round here, and then it will be trying to stimulate a cell that is still refractory, okay, and therefore the signal will die here. It'll boom, gone, okay. So, the hope is that with amiodarone you can kill the circus rhythm because the cells just won't be ready and won't have recovered from the previous action potential by the time that the electrical signal gets back round to them. Okay, and the hope then is that once this is gone, the sinoatrial node will take back over and you'll return to normal sinus rhythm. Okay, so that is amiodarone and how we hope amiodarone can be used to treat the circus rhythm. So it's another anti-dysrhythmic drug. Well, I've just used the other word, antiarrhythmic or anti-dysrhythmic drug. Okay, so amiodarone is usually put in class 3 of the Vaughan-Williams classification of anti-arrhythmic drugs. We've talked about the fact that beta blockers are in class 2, calcium channel blockers are class 4. We haven't mentioned class 1 yet. Digoxin is in none of the classes of the Vaughan-Williams anti-dysrhythmic drugs or antiarrhythmic drugs. Okay, right, so that is atrial flutter then. Now what I want to go on to is atrial fibrillation. Okay, so atrial fibrillation is even more dramatic than atrial flutter. Atrial fibrillation is again going to be caused by mainly reentrant loops. However, it's going to get worse. It's going to also have loads of ectopic foci as well. So atrial fibrillation is going to be caused by both of the mechanisms that we've talked about so far. So you're going to have ectopic foci in the atria, and you're going to have reentrant loops, potentially more than one of them. Okay, and they're all going to be driving electrical signals to propagate through the atria, so you can get absolutely huge rates of electrical signals propagating through the atria in atrial fibrillation. Okay, so in atrial fibrillation, I'll just write this down, we're going to have reentrant loops and ectopic foci both producing electrical signals that are going to be propagating through the walls of the atria, and therefore we can end up with massive electrical stimulation. So reentrant loops and also ectopic foci. So what then can the rate of electrical signals propagating through the atria actually reach up to? How many times can the atria end up contracting in a minute in atrial fibrillation? Well, it can go up to actually 500 beats per minute. So the atria can end up contracting at a rate of 500 beats per minute. Now evidently that is extremely extreme, and the atrioventricular node will certainly not be conducting all 500 of those down to the ventricles, but it will conduct quite a lot of them, and therefore the ventricles will end up contracting at a higher rate than we want them to be contracting at. Okay, so now let's talk about what the ECG is going to look like in the case of atrial fibrillation. So it's going to be a bit more of a mess than with atrial flutter. In atrial flutter we had these nice atrial flutter waves because the electrical signal was continuously being produced from one place. It was always coming from the reentrant loop. In atrial fibrillation it might be coming now from all over different places of the atria, because we've got potentially multiple reentrant loops throwing out electrical signals all over the place. We've got potentially multiple ectopic foci throwing out electrical signals. So where the electrical signal is coming from can be varying all the time. So what tends to happen is the P waves look more of a mess in atrial fibrillation. So what it might look like is something like this, basically. Okay, and then of course dotted around the place what you'll have is where the electrical signal has been allowed to propagate through the atrioventricular node and has caused ventricular depolarization. So occasionally you'll have a QRS complex dotted around the place, and maybe a little bit of a T wave with lots of little P waves messing it up here. Okay, so this is what the ECG might look like in atrial fibrillation. Now, of course, this is just a cartoon, but it gets the point across that because you've got all of these different parts of the atria trying to drive the pace, so potentially multiple different reentrant loops and multiple different ectopic foci, that some of the P waves will be upright, some of them will be inverted, depending on which pacemaker, if you like, is actually causing that electrical signal and where it is actually positioned. So of course, if the means by which the electrical signal has been generated is coming from at the top of the atria, then we'll have anterograde conduction, and therefore we'll have upward deviation from the isoelectric line. And if the reentrant loop or the ectopic focus is near the bottom of the atria, then we'll have retrograde conduction of the electrical signal up the walls of the atria, and therefore you'll get downward deflection from the isoelectric line. Okay, right, so that's what the ECG then will look like for atrial fibrillation. What are the different treatment options then for atrial fibrillation? Well, all of the drugs that we've just talked about, beta blockers, calcium channel blockers, digoxin and amiodarone can help. Okay, of course, beta blockers, calcium channel blockers and digoxin, the main aim there will be to try and reduce the number of electrical signals that are actually making it from the atria to the ventricles to try and prevent tachycardia. Okay, yes, the atria are a lost cause, but let's make sure that the ventricles aren't contracting too regularly so that we still maintain a decent stroke volume and stay alive. Amiodarone, the aim of that will be to try and kill off some of these reentrant loops and therefore try and stabilize how many electrical signals are being produced in the atria. Other options then, another option is that you can actually do what's called pace and ablate. Okay, so this is a sort of tongue-in-cheek name for this treatment. So really it should be ablate and pace rather than pace and ablate, because that's the order that you would actually do it in. in pace and ablate treatment for atrial fibrillation, the idea is to completely disconnect the atria from the ventricles. So we acknowledge that the atria are a lost cause, and what we're going to do is we're going to cut them off from the ventricles and instead use an artificial pacemaker to drive ventricular contraction. So the idea then is to use catheter ablation to destroy the atrioventricular node, and if we destroy the atrioventricular node, then of course electrical signals from the atria cannot be propagated down to the ventricles. So yes, the atria can do whatever they like, but they're not going to influence the ventricles at all. Now of course, just doing catheter ablation of the ventricles would be of the atrioventricular node would be a very bad idea, because then the ventricles wouldn't contract at all. They would contract, because remember the His-Purkinje system, the cells of that conduction system do have pacemaker activity, but it's very, very slow, so they'd be beating at a very low rate, and we'll discuss later third-degree heart block, indeed, where that has actually happened, not with catheter ablation, but the ECG that you get, you have very, very rare QRS complexes due to the low rate at which the His-Purkinje system cells actually do generate electrical activity. However, what we're going to do is then insert a single-chamber artificial pacemaker to drive ventricular contraction. So in pace and ablate, we would ablate the atrioventricular node to prevent the atrial electrical signals actually being able to influence the ventricular activity, and then what we'd do is we'd insert in a single chamber pacemaker into the wall of the right ventricle, and then we'd allow that to generate the electrical signals that would then propagate down the ventricular myocardium and actually trigger left ventricular and right ventricular contraction. Okay, and of course we can then determine the rate at which the ventricles will contract, and we can make it nice and normal. So that is an option for treatment with atrial fibrillation. Now, let me also mention something that you must do when you've got someone on atrial fibrillation, with atrial fibrillation rather. You must put them on an anticoagulant. So people with atrial fibrillation are put on an anticoagulant, generally the very powerful one, warfarin. Okay, now why do they need to be placed on an anticoagulant? Well, if you're in atrial fibrillation, the atria are potentially contracting at a rate of 500 beats per minute. That they will not actually be contracting and relaxing with that rate. Okay, what will be happening is they'll be in a permanently contracted state, and then they'll try relaxing a little bit, and then before they've got anywhere, basically, they will then be contracting again. So what it will look more like is that the atria are shuddering, basically. They're not actually doing a nice contraction and then relaxation, contraction and then relaxation. Instead, they'll just be in the permanently contracted state, shuddering. Okay, and that means that they're not actually really moving blood that much. So what can actually happen is, in atria that are fibrillating, you can actually get thrombi formed on the wall of the fibrillating atria. So you can get coagulation occurring, you can get platelets aggregating together to form a platelet plug effectively on the side of the heart wall, and then you can get the intrinsic and extrinsic coagulation cascade being activated there, and you can form fibrin meshworks to tie all of the platelets together. So people in atrial fibrillation are at huge risk of thrombus formation within their atrial chambers. And of course, if you get thrombus formation in the atrial chambers, what can happen is bits of that can break off, and you can get thromboemboli shooting around the circulation, and those can lead to myocardial infarction and stroke. So to prevent myocardial infarction and stroke due to thromboemboli blocking blood vessels of the coronary and cerebral circulations, we place people who are suffering with atrial fibrillation on a powerful anticoagulant, and the usual one is warfarin. And warfarin, of course, works by preventing the synthesis of loads of the coagulation factors. In particular, it prevents the synthesis of coagulation factor 2, 7, 9, and 10. So all of these coagulation factors, they require, in order to work, the uncommon amino acid, gamma carboxyglutamic acid, and to produce that amino acid from glutamic acid requires vitamin K in the reduced form. Okay, and every time you produce one of these gamma carboxyglutamic acid residues in one of these coagulation factors, you turn the vitamin K in the reduced form into vitamin K in the oxidized form, and to prevent you running out of vitamin K in the reduced form, you have to continuously convert the vitamin K in the oxidized form back into the vitamin K in the reduced form, and that's carried out by an enzyme known as vitamin K oxide reductase, and warfarin works by inhibiting that enzyme. And by inhibiting that enzyme, it prevents you from remaking the reduced vitamin K, and with no reduced vitamin K you cannot change glutamic acid residues in these coagulation factors to gamma carboxyglutamic acid residues, and without those residues these coagulation factors do not function. So people taking warfarin, they do not produce any functional coagulation factor 2, 7, 9 and 10, and without all of these coagulation factors the intrinsic and extrinsic coagulation cascade are completely shut down. I mean 2 and 10 are absolutely essential. Without them you cannot have the coagulation cascades operating, so you cannot produce fibrin meshworks, and without fibrin meshworks the platelets will not hold together. They have very weak crosslinks between each other in a platelet plug, and they require the fibrin meshwork to actually hold them together and make it structurally sound. So without that fibrin meshwork, it's gone. Okay, so coagulation won't occur without these coagulation factors, and hence you're not going to get thrombosis occurring on the walls of the atria in people with atrial fibrillation. So if you've got someone with atrial fibrillation, they will be on an anticoagulant to prevent thrombosis occurring from within the walls of the atria. Okay, right, so we'll have a break here, and in the next video what we'll move on to is arrhythmias that arise due to problems in the atrioventricular node. In particular, what we'll talk about is atrioventricular node reentrant tachycardia, and also atrioventricular reentrant tachycardia, which is a difficult one to classify into the supraventricular or ventricular category because of the fact that it involves both the atria and the ventricles. Okay, but we'll put it in the middle, so we'll put it as we're moving from supraventricular to ventricular. Okay, so see you in the next video.